Good evening, everyone, and welcome to Go Rural Virtually. I'd like to begin by acknowledging that I'm hosting Go Rural Virtually from the lands of the Turrbal and Yagara peoples, and recognise that this land has always been under their custodianship. I also acknowledge the traditional custodians of the various lands on which we study, work, and live today. I pay my respects to elders, past, present, and emerging, and celebrate the diversity of First Nations peoples and their ongoing cultures and connections to the lands and waters of Australia. I also extend my respect to all Aboriginal and Torres Strait Islander people with us tonight. My name is Meredith, and on behalf of Health Workforce Queensland, I welcome the health students, organisations and speakers who have come together to be part of what promises to be a thought-provoking topic. Collectively, we will explore managing aggression and violence in healthcare settings by participating in an interactive discussion with health professionals and researchers. Tonight's speakers are excited to have this opportunity to share their stories and knowledge with you. However, should this discussion raise issues or concerns for you, please feel free to join our virtual safe space at the end of the session. Because Go Rural Virtually is an interactive discussion, we encourage you to type your questions into the chat function. And as questions come up, I'll pause the conversation and ask our speakers to respond. So please feel free to ask as many questions as come up for you. So workplace violence directed at healthcare workers from patients and bystanders is a serious issue nationally and globally. As healthcare patients and clients, we've become very accustomed to verbal and written warnings of a zero tolerance towards aggression and violence. But do we know what lies behind these words? And what exactly do we mean when we say aggression and violence? Alicia, you've spent many years working in healthcare research and supporting the safety of rural healthcare workers. What do we mean by workplace violence?
Thanks, Meredith. So the first thing that it's important to know is that violence itself is a social construct. So violence is not a proper noun. Violence is not something you can hold in your hands or something that you can necessarily touch like an apple or orange. It's something that we construct as something in our mind. So we essentially know it when we'll see it. And I know that's a very technical term for it, but I suppose in our minds, we have this understanding of this is what violence or aggression actually means. Violence can be quite situational and it can be quite different what is considered to be violence or what is considered to be aggression in different settings. So as an example, if I'm running really fast and I see someone in front of me and they turn back and look at me and I keep running and I chase them down and I grab them around their stomach and wrestle them to the ground. On a football field, I'm a hero, but if it's a stranger in a park, I'm a criminal. So what we see as violence in those two situations is very different because of the expectations on how we will act and the expectations on how other people around us will act. So this evening, we're going to be talking about workplace violence. And there's three things that we need to really know this discussion about workplace violence. The first thing is that it's at work. So we are talking specifically to a health.
Yeah, because we're losing your sound. Yeah.
Sorry about that. So
that's okay.
Now I've gone dark. And I think that I was telling you about the three elements of
Yes.
workplace violence. So the first part is that it happens at work. So it's integrally associated with the fact that people are working in a healthcare setting. So that's what we're talking about. The second element is that there is someone who is doing this. And in this situation tonight, we're discussing that person as being the patient or the person who is a family member of a patient who's coming and behaving in a violent manner. And the third part is the actual violence itself. And we're defining that maybe as something that is a threat to cause harm or an actual act that causes harm to a person. So I think that sometimes when we have violence discussions, it can be very broad and we can include quite a wide definition of violence, but I think it's important to narrow it down. So this evening we are specifically excluding those situations where someone annoyingly says, hey doll instead of hey doctor. That's not actually what we're talking about tonight. We're talking about situations where there is a threat or an actuality of a cause of harm to a person at their place of work.
Thanks, Alicia. Beck, drawing on your 20 years of experience across remote area nursing, emergency nursing and clinical education, what would you identify are the clinical drivers that contribute to patient violence and aggression?
So definitely in the Northern Territory, I can speak to substance use and misuse and the escalating rates of mental health and untreated mental health conditions in all parts of our population. From my work interstate, I think that's really no different. Some of the elements of which different substances are being misused is different and more prominent in other areas of Australia. Alcohol is a major driver of aggression and violence in the Northern Territory, whereas some of the eastern seaboards, there's other substances or illicit substances involved as well. I think Brodie could probably speak to some of the work he does on the eastern coast about different elements other than alcohol, perhaps.
Brodie, do you want to pick that up?
Yeah. So just a bit of just to introduce where I'm coming from. I'm a paramedic with Ambulance Victoria. I'm in regional Ambulance Victoria, but I've also just submitted my PhD, and it's on the topic of workplace violence. So I've thought about it a bit. A couple of our studies were on this topic of trying to categorize perpetrators of violence, and so that's the patients and the bystanders, the people who are responsible for violence. So perpetrators is a bit of a loaded word, but it's the people that are responsible for the behaviour. So what are the associated conditions maybe with them that are leading to violence? And we did interviews and focus groups with ED nurses and with paramedics. So we're looking at emergency healthcare. So not in all of healthcare, but it might be applicable to most of healthcare. But the categories that consistently came up, there was 5. So there was patients that had no medical reason to be violent. And so this came up with things like attitude and expectations. So there was no real other reason except for frustration, things like that, as to why people became violent. And that's really common. You see it a lot. The second was a physical health issue. So there is some kind of physiological thing happening, like a hypoglycemic patient or a postictal patient after a seizure, or maybe a hypoxic patient who doesn't have enough oxygen in their brain to be able to think clearly, and they're sort of just reacting, and that can lead to violence. Again, that becomes a bit debatable when you think about if it's intentional or not, but people physically. Then there's mental health, so patients that have a mental health problem, that's really, really common. And common things with patients that were psychotic or suicidal, and then psychoactive substance use, so alcohol and other drugs, again, is super common in our context. And then the 5th category they came up with is repeat offenders, or repeat perpetrators. Offenders is loaded again, but repeat perpetrators who are continually doing the same behaviour, and we see them frequently. But generally, they will be made up of some other cause that's underlying that, whether that's a physical health issue or mental health issue.
Right, thanks, Brodie. That's very broad but important categories that you've outlined for us. Rebecca, I just want to turn to you now, because you worked as an assistant in nursing and aged care for 5 years. And this role brought you into contact with patients affected by cognitive deficit. Can you take us through how this contributed to the type of violence and aggression you experienced in this environment?
Sure, Meredith. So I dealt predominantly with persons who had no real awareness of where they were and what they were doing. And the behaviours that we did witness, it could be things like punching, kicking, spitting and other things. The way I saw it, it was all coming from someone who had no idea who I was, what I was doing and why they were there. and they were just very afraid and didn't know what was happening.
And maybe just for the benefit of the students, can you just describe the kind of what the workplace was like? Because it wasn't just probably our stereotypical aged care facility, was it?
No, it wasn't. The facility I was working in had absorbed a lot of residents from psychiatric facilities that had advanced in age. Many of them had been residents of these facilities for decades, and they simply became old enough and frail enough that they no longer required the locked units and the specific care that came from those facilities. So they came over to the nursing home for that that end of life period.
So obviously that cognitive deficit, I guess, is was very predominant. What types of aggression did you experience from those patients?
There was plenty of incidents of they'd call it verbal. Things like, if you say, a lot of seething and spitting, swearing, some threats of violence. I won't go into specifics, but some of it wasn't nice, but generally coming from someone who didn't really know what they were saying.
Yeah.
On the physical side, there were persons who, one fellow managed to grab me and drive me into a wall. There was one incident where I was even kicked in the head by an aged person. It was a bit of a shock at the time.
Yeah.
We have had a question come through, Meredith, from another Rebecca, saying, I have 12 years experience in aged care. Why is it that patients play up and get violent when there is a full moon? Have you come across that, Beck?
Okay, so look, if you do a quick Google Scholar search for lunar effect, you might find your answer, which is there's not a huge amount of research data that would support that. So it is, well, at the moment, there are elements to perhaps hormonal rhythms in humans, but I'm not sure that there's enough evidence to say. I've worked in nursing homes myself at the beginning of my career, and I would have sworn by it back then as well. I think we're more primed ourselves to consider that there's misbehaviour going on at a full moon. We're ready for it. And then it comes not as a surprise. So no, I don't think there's a huge amount of evidence.
I guess it's just the evidence that we experience in day to day, even outside of healthcare settings. So maybe there's a PhD in that, someone. Brody, your role as a paramedic means aggression and violence are part of your working life. Can you share with us what that looks like for you?
Yeah, so it's something that we think about all the time because we're quite vulnerable. I work by myself at the moment, but otherwise we only just work with partners, never anymore. So it is a very scary thing sometimes. You walk into an unknown place, like a house, like somebody's house. You don't know what you're going to find in there. So we try and do a bit of training on situational awareness and things like that to prepare us for that situation. But it can be really actually quite terrifying when you go to some dodgy areas in town. You don't know what you're going to find, and it feels quite common that we're faced with violence, and it feels like a really unfair problem. So we're not showing up to work to punch on with people. We're showing up to work to try and help people and have value, and that's what we do. So to come to work with good intentions to try and help people, and then you get spat at, or you get punched, or get wrestled, or something, it's a really frustrating and unfair problem. The things we probably see the most, a lot of my research was done in EDs when it comes to specific presentations for violence. It's a bit difficult to do that research in the ambulance service, but from my experience Majority is to do with patients with mental health problems or with drug and alcohol abuse. And a lot we do deal with police. So we're very quick to get police to help us out in situations. And it sort of goes both ways. Like, we'll often run away, wait for police to come and help us out. We'll leave someone if they're sick. That's not our problem. If we weren't there in the first place, they were still going to be sick. So we're happy to sort of run away and wait for police to come and help us. And then the other way around, police will often be wrestling someone on the ground, and we'll come along with some very fancy medications to put them to sleep.
Yep.
So yeah, it's a very broad issue, and it's a very important issue that's really difficult to manage. Most of my experiences have been with mental health issues, and it's often like not just straight cut and simple mental health problems. It's often a combination with mental health and with drug and alcohol abuse. It makes things so challenging to find out what the problem is, to try and de-escalate. And our fallback tends to be sedation, which isn't necessarily great, but keeps us safe. Interestingly, we do end up going to places like nursing homes and stuff as well, or patients with dementia in the community, and they become some of the worst jobs you ever have to do, where someone doesn't have capacity to make decisions and they're sick, and we tell them, you need to go to hospital and you don't have the ability to decide that, so we're going to force you to go, and then you end up having to sedate someone because of that. That is the worst, because someone is confused and doesn't know what to do and they lash out. They are some of the most complex and horrible jobs to deal with, and you feel terrible afterwards. But we see that a little bit in ambulance as well, I suppose. When it gets to the point where the aged care facility cannot manage that person anymore, then we'll come along to try and manage that. And aside from facing violence, which in those situations you're never frustrated at the person, you just feel terrible about the whole situation. We also see a lot of behavioural problems in young people at the moment, which I don't know if this has been a thing going on forever, but we see a lot of violence from young people with cognitive, maybe not cognitive disabilities, but like, we have a lot of frequent presenters in my area with Asperger's and with oppositional defiance disorder, and they take up a lot of resources really frequently. It's really difficult to try and manage. And they're another really ethically complex case to deal with, because it's often pediatrics, and it's not simple to just sedate and put to sleep a child. So very vulnerable. We find ourselves in very complex situations a lot of the time.
Do you feel like you have a good working relationship with the police?
Yeah, we do. Yeah. So when I first started in an ambulance, our management would often try and coerce people to go into scenes that were dangerous. And I bring this up because this happens in other ambulance services still, but our management stopped doing that and said, if you feel uncomfortable, if the information provided you makes you feel like it could be potentially violent, then you don't have to approach the scene. You can just wait for police. And that was one of the most amazing things that we've had to support us. So if we get some information that we think this is going to be a little bit dangerous, then we call police and they will meet up with us before we go there. And I've not once had a problem. The police are always really great. And the same goes the other way around. The police obviously call us if there's any medical issues, and we're there pretty quickly to help out with that. But any violence as well, if there's a potential medical reason or a mental health reason, then we'll take over the patients and we collaborate really well in that situation. Yeah. Without the police, it would be a horrible environment.
Yeah, you need it. You know, I guess we don't assume that police are going to be part of the healthcare team, but like security officers, you know, they have become part of the healthcare team. One
other thing, sorry, with police specifically, is there's some models of patient diversion away from EDs for mental health or patients with mental health problems, because the ED is the last place you want to be if you have a mental health problem. So there's some models that just have police and a mental health clinician who will try and manage someone in the community without taking them to hospital at all. And so that's an interesting concept as well that I think could have a lot of value.
Have there been any moves, Callan, you might be able to answer this. Have there been any moves to kind of, as just picking up on what Brodie said, to kind of move mental health patients into a separate kind of triaging area? Because my understanding is they commonly become unmanageable because it's such a stressful environment. It's noisy, there's lots of movement, they have to wait a long time, it just gets too much. But has there been any move to change their experience?
Yeah, there definitely has. For over here in Perth, one of our major emergency departments actually built almost a drunk tank within the emergency department for basically the drug psychosis side of things, because over here in Perth we're having an absolute terrible time with ice. So we're seeing huge numbers of people coming in with drug psychosis, unmanageable, unbearable, and just flooding the emergency department. So they're being put into areas that can be completely locked down, monitored from safe places, and put there so that they can't hurt anyone else. They can only do damage to the area itself. There is plans to do this with all the other emergency departments and have safe rooms or areas. The problem is the numbers that we see is just too great for the actual area. It doesn't matter how big you actually make it. If it's the old saying, if you build it, they will come. And unfortunately, we fill them quite easily.
Well, I guess you could reverse it and just have a safe space for the people that aren't unmanageable. And but it's it's great to hear there's that innovation starting to take place, because clearly it's really needed. Tony, I'd like to turn to you next. Your role as a medical centre receptionist in a rural location brings you into contact with a lot of transient patients. What expectations do these patients commonly have regarding access to healthcare?
Yeah, it's quite amazing sometimes how people will pack up their caravan and leave from the other side of Australia and expect that they can walk into a medical centre and receive the services that they require. You know, their lack of ability to be organised and plan ahead, and they've run out of meds. And so we don't see physical aggression quite so much, but you do get those patients that are annoyed and they can get a bit aggressive in the sense, well, why wouldn't you have an appointment? But as everyone knows, rural medicine is so short-staffed that it just puts more pressure. And then sometimes they'll be quite unwell. So they've become unwell in their travels and think that they'll just try and push on and keep going. They'll find somebody that's going to help them. But as they head out towards Ravenshoe, they're heading further and further away from facilities. So sometimes when we sort of point out to them, you need to go back to where you came from, because that's where the help is. They don't like it very much. And, you know, we have been particularly short on doctors, so it has been quite difficult the last couple of years.
What's the common wait time for an appointment at your practice?
At the moment, about a week, but 3 months ago, it would have been up to 3 weeks. We were short. We've managed to get another doctor, so it has eased slightly, but sometimes it was up to 3 weeks unless it was an emergency. So we tried to save emergency appointments or whatever, but they tend to go very quickly because we need them, or the doctor will use them, or, you know, yeah. And so that's quite a long time, and, you know, you don't know that you're going to be sick 3 weeks ago.
That's right. And I understand another practice has closed recently, which would be putting added pressure onto your practice to take those patients on board.
That is really going to be quite difficult, because it's 50 kilometres away from us, and none of the practices in that area are taking new patients. So they're coming, you know, they're phoning for the closest possible doctor. But my concern is we're going to get a lot of elderly patients with complex conditions and have to drive 50 kilometres to their GP. And I can see that being quite a problem when they become really unwell and are not up to driving, you know, and the doctor's not there to assess them. And yeah, it's going to be very difficult.
Yeah, so it just compounds people's frustration and
yeah.
And as you say, the
unfortunately for receptionists, we don't tend to see the physical aggression or violence that some of you other guys see, which is pretty unfortunate. But you can feel fairly threatened at times, and it's not that we take it personally or anything. You just have to deal with it and call it out and say, just hang on a minute, I'm trying to help you. But you can sometimes it's understandable. You know, they may have an infection, that a UTI sometimes bring out all sorts of personalities that, yeah. So, but it is quite difficult at times.
Yeah. Thanks, Tony. Callan, you work as a workplace violence and aggression coordinator for the South Metropolitan Health Services in WA. Even though health service providers say they don't tolerate violent behaviour, undoubtedly there already exists high levels of tolerance in health workers' workplaces. What's your experience of this?
I really dislike that phrase, the zero tolerance policy. As you said, there is all levels of tolerance. The cognitive impairment one, you know, you have to tolerate that. It's not something someone is doing consciously. They're not perpetrating against you in an actual manner that they know they're making these decisions. So you will tolerate that. You'll allow it. You'll move past it. That you can't kick them out of the hospital because they're there for that care. So I feel that terminology has failed, and it fails our staff. We're not supporting them with having actual terminology and supportive communication from up above. We've got this exhausted term of we have zero tolerance, and you watch the staff say it, they don't believe it as they're saying it. You watch the person who's heard that 30 times already, and they don't believe you as you say it, and then it just continues down that pathway. Whereas you need to move away from that, accept, okay, we do have some levels of tolerance. We need to figure out something that works better. We need to start to adapt to better communication. We need to have much more external, internal media communications that go outwards and start to shift and change the culture around coming into a hospital, and live and breathe that, you know, having an actual communication style that makes everyone feel a part of the healthcare, and that they're not allowed to do that in a hospital. They're not allowed to behave in such a manner that they're making a poor young nurse or a doctor feel unsafe in their working environment. It's something I've been pushing quite hard to try and remove from our health service, because we don't have an official zero tolerance policy, yet everyone has just jumped on it and keeps using it. And yeah, it's quite failed.
Yeah, well, it puts a massive barrier up, because you've got to deconstruct that perception that there is a zero tolerance. Brodie, would you like to add anything to that?
I would, yeah. I completely agree with Callan. Like, zero tolerance policies are a lie in healthcare. Zero tolerance policies are great outside of healthcare, at retail and stuff. That's amazing. That's really good. It's really supportive, and it will work. But in healthcare, it does not work at all. And it's interesting because you tell staff we have zero tolerance for violence on one hand, and then you say on the other hand, now we need to do de-escalation training so that you can teach people to stop being violent. You have to calm them down. You're like, well, they don't meet. They're complete opposite things. So no tolerance to violence, yet let's tolerate violence and be nice to people and try to de-escalate it a little bit. So you're right. It's flawed. It doesn't work. We need something different. And I don't know what that policy is. I think a fair bit of work needs to go in to figure out what that is. In ambulance, it's a little bit different because we run away. So if someone's violent, we sort of get out of there. So we don't tolerate that a lot. We do tolerate a lot of violence. Like we've got some examples in the last week where a patient was pretending to have a seizure and then just booted the paramedic in the ribs, and they continued to, you know, care for the patient, de-escalate and stuff. So they tolerated it a lot. But yeah, it's complicated, I think. But we can often run away. We do end up having to go back with police at a later date. So eventually we are going back to manage that violence. But in a hospital, you can't run away. You've got to manage that. And so zero tolerance doesn't work at all.
It's funny that you mentioned
Sorry,
I was just going to say, it's funny you mentioned the de-escalation side of things in with zero tolerance, because that most certainly is an issue we're having over here. Is the de-escalation techniques are, if you're getting sworn at, take it in and apologise and try and get them to stop doing that. Well, that just lets them know that it's okay to keep swearing at me and keep calling me a whatever you want to call me. And then this poor medical staff member, clinical staff member, is being told, you need to allow this person to vent and call you all manner of wordings. Like, I'm a security officer from a past life, and some days it gets to me, and you know, I've got quite a thick skin. So for someone who's quite fresh into the clinical world and being told, allow them to call you all these horrible names, like, what kind of damage does that do to someone?
Yep. Yeah.
Can I jump in there? So in the research that we were doing, we found that there were different understandings of what constitutes unacceptable behaviour. And that was one of the issues, because staff had different ideas and they weren't backing each other up on that. So there was an incident where a nurse had a patient behaving badly, and the nurse said to the patient, look, if you're going to do that, you can leave. The patient left, and then the doctor chased that patient into the car park and brought her back and apologised to that patient. So I think that it does need to be a shared understanding, and really one of the important things for you guys as students here listening is to back up each other as a team. And if someone is feeling unsafe, don't question whether or not they're feeling unsafe, but back them up, because then they can back you up when you're feeling unsafe later. And it needs to be done as a team effort, without allowing this to kind of get in between you and have people second guessing whether or not what they're experiencing is actually something that crosses the line into aggression.
Yeah,
I actually had a difficult conversation with a 30+ year psych nurse. He had become quite tolerant to all manner of verbal aggression, and it didn't bother him, and that's quite all right. But you know, when you go to that person who doesn't have that high threshold and feels that being sworn at once is too much, you're both right. You know, but the one who's the older, educated one who people look up to, they should really be setting the example and saying, no, you're right, they shouldn't have sworn at you like that. I've become a bit more tolerant of it, but no, you are right, and support them, like you said, Alicia.
Yeah, we have a question, which I think is a good time to bring it up. Do you have any tips on how to de-escalate a situation and try to calm a violent patient down? Anything in particular that works well in your experience?
If they're violent, you can't de-escalate them. They've already escalated. Have security there as soon as humanly possible. If you're in a rural setting, then try and be more situationally aware and identify as early as possible and put yourself in a safe space. There is a time and place for de-escalation, but if you're not continually using those skills, you will need to be continually trained on it. Otherwise, you won't retain that information, because you're obviously learning all these clinical and focusing on all your clinical and medical education. So de-escalating a violent patient, it's too late. If you're trying to de-escalate someone who is getting somewhat aggressive, try, I don't agree with the de-escalation that's currently, the models that are out there currently. There needs to be work in that. So call security or put yourself in a safe place.
And I guess the other side of it, sorry to butt in, is just like when you're going through your ALS algorithm and you get to your 4 H's and your 4 T's, you actually have to treat the cause. And you know, at the end of the day, if someone's got sepsis and they've got delirium or they've got a UTI, reasoning with people and using some of these traditional de-escalation techniques is actually not going to make it any better and could actually make it worse. We've got safe rooms in remote because often police are hundreds of kilometres away. So every nurse or clinician that works for us is really quite well orientated to where they are. So yeah, I agree. When violence is already occurring, it is too late.
One other thing, if I can add to de-escalation, is that when you get in the workforce, you'll see people that do the opposite of de-escalation and deliberately escalate situations. And that is like the epitome of what not to do. So if you're trying to de-escalate, you've got a good attitude already, right? If that's your position, then great. But Brody, step, right?
Kicking people out of the ED waiting room is a really quick way to empty it, isn't it? I think so.
Yeah,
if you escalate people in front of you and you kick them out.
I'm referring to. Yeah.
No, it's not a funny topic, but I agree, it happens as well. Yep.
Mm.
And people are often at their own point of saturation in dealing with it, and that's their way of pushing back, and probably have burnt out.
Mm.
So maybe this is a good opportunity to start having a discussion about training. Rebecca, when you worked in the high care environment that you spoke of earlier, what training were you provided?
In terms of dealing with dementia, we had some training, but with actually managing physical or verbal aggression, that was really lacking. It was talked about and promised, and it was promised pretty much the day I started in the last facility I worked at, and just never eventuated.
So no training to speak of in your experience. Beck, is it generally assumed that staff have had training prior to starting work in their chosen field?
No, we look in some areas of the health service, I'm not going to lie, that's probably true. I can only speak for my sphere of influence, but we don't assume it because we have such a high risk environment. We can't put people out unless we're really sure they're quite experienced. If not, there's formal training packages. Callan might not agree with some of the content of them, but there's also policy and there's also support. So while police might be hundreds of kilometres away, your manager is on the phone 24/7. So we have a 24/7 on-call manager, and it's their job to support your decision-making, just like Brody's service is supported not to attend. If any of our remote area nurses feel that there is an unsafe situation, all they need to do is call the telephone line and be supported to say, I'm not attending. It is too unsafe. We learned so many big lessons when Gail Woodford was murdered. We will never place our staff or ourselves in that situation. I can't say ever again, but we will not do it willingly or simply because we don't have a process or a policy or support in place. So yeah, I think there's plenty of training available in certain elements of the health system around Australia. Aged care is chronically underfunded, chronically under-resourced, and doesn't fit politically high up on the agenda anywhere. So to produce or provide a really high-cost training package to staff that aren't registered professionals, so your care attendants, would be a huge financial burden on the system, and I'm not sure that system's prepared to take that cost on yet. I'm just speaking externally. I don't have any vested interest in the aged care system, so I don't want to speak as an expert, but I don't see it happening quite soon.
Well, speaking as somebody that is vested in the aged care system, because it's like,
and we all should be there
than not.
We all should be.
I think I have to agree with you. As you get older, it's very easy to become invisible, and also not to have a voice. And obviously that has really impacted upon our elders' experience.
Meredith, the other people that don't have a voice in this situation are the untrained care attendants, who are often teenagers. Yes. Migrant workers, people whose English is probably not even their first, second or third language. and who are really often poorly paid and aren't unionised and don't have a professional or regulatory body that's really behind them. Sorry to butt in.
No, I think that's a really valid point, very valid. Brodie, how did the training you were given as a paramedic hold up in real life situations? Okay, when I started, our training at induction was like a 2-hour self-defense training. And in my mind, that was the worst possible thing. It was far worse than no training, because we had a whole heap of paramedics with sky-high confidence that they could be a kickboxer and fight, with zero confidence because they've had a 2-hour session, right? And that is the most dangerous thing I could possibly think of. So, you know, learning how to do a like arm lock or something on someone and run away, but you can't do that if you've practiced it for 2 hours. So that was really dangerous, and you'd never used in reality. So the de-escalation strategies are what you would employ most of the time that we learn at university. And a lot of the time it just comes to like online training packages, and then it's up to you to get the value from it. But a couple of years ago, Ambulance Victoria got a heap of funding from the government, and they put together a virtual reality training course for violence, which I think was one of the first times that had been done. And that was actually really, really interesting, where you're given a few different scenarios and you had to identify where threats were. So it was really about situational awareness. And that was actually great. That was pretty good, but it was a one-off thing as well. So it would take you like through somebody's house, and you would like had to look around and see if there's someone in another room, and then it had a scenario.
Sounds like Call of Duty, Brodie.
Pardon?
Sounds like Call of Duty.
It basically was, yeah, but for ambulance, right? And you don't have a gun. But it was actually, I was really impressed. It was really good. But yeah, that's about it. And then like from a research perspective, there's no evidence that staff training is effective at reducing violence. So the data says that staff training increases violence because staff get trained and then are more likely to report violence, and so the reporting goes up. But yeah, there hasn't been any evidence to say that anything's really effective, so we don't really know what works. And from some of our data, staff feel that there's too much focus on training of staff rather than other kind of interventions. That's where the violence prevention is really targeted at, is to teach the staff to stop it, and that puts the responsibility on the staff. And so if someone's violent, they'll be like, well, we trained you to stop that and you didn't, so that's your fault. And that's a big problem. That's not the culture we have at the moment, but that's the problem that some people have when the focus is on just training.
Yeah, we've kind of gone the other way. Every time you leave a remote clinic unit, you have to do a risk assessment of where you're going, who potentially could be there, what dogs are in that person's yard, what's your escape route, how do you even park your vehicle when you pull up at the front so that you can pull away really quickly if your risk assessment didn't identify that actually there's a crowd in the front yard and there's a big problem. Yeah.
Beck, how do you deal with I guess, you know, what I think it's commonly called, you know, your repeat offenders? Do you have a register, or
so
yeah, how do you know?
Part of the risk assessment process is this patient or client known to you? So I'm generally talking about remote communities. I manage a lot of different areas, including prisons. So I'm not speaking to those areas. I'm probably really speaking specifically to remote communities. These communities generally are anywhere from 60 to 600 people, have a population of that size. More often than not, your repeat offenders, for want of a better word, have a clinical file note alert on their file to say that they are a risk to staff. And it is a full expectation and fully supported by our organisation that they are looked up before you attend. You have to do a risk assessment, even if there's a CPR situation. So even if you have a call over your on-call phone to say someone is having a heart attack and they've stopped breathing, there is still a risk assessment that's done before you arrive. So avoidance is the biggest strategy. We avoid placing our staff in those situations. There are plenty of clients that have very long and extensive mental health histories that are really well known to us, and unfortunately a lot of their management in remote can't wait for a police officer to attend, and they potentially are a risk to themselves and to others. Where the risk to staff is not so large and there is some intervention that can be started, more often than not, there's a medical form of restraint, in terms of like chemical restraint, basically. And we can't maintain the care of clients in remote overnight. We don't have the staff, we don't have the facilities, so they're often retrieved, which means generally by air, because I'm talking about a really, really vast distance, millions of square kilometres. So often they're retrieved by air ambulance. So we've chemically restrained them. Often the doctor arrives with a large team of support, and the person is often intubated and returned to the major tertiary hospital, where they might remain in ICU for their mental health condition for a couple of days, intubated, before we can bring them out when their agitation has decreased enough.
Yeah. Callan, I guess, I'm interested in hearing from you about the processes and procedures that you have in place in terms of training. It's quite clear that in Beck's area, in the Territory, there's very clear guidelines. Are those guidelines as clear in urban settings?
Yeah, they're very comprehensive, too much so though. We've got some that are 30, 40 pages long, and I've had to review them, and I've almost fallen asleep reviewing them. Our training here in urban areas, I actually did a comprehensive review of all of our training packages across our health service centres. I think there's 7. Each one of them don't meet any kind of real standards. Each one of them doesn't really meet the requirements of our Work Health Safety Act. One of them that was actually developed specifically for a response to a coronial inquest didn't meet the requirements of that inquest. We have a lot of just old redundant teachings, just teaching the generic sort of things that we've seen in the past, basically what Brodie was talking about. We have one training that no longer is being trained. It was about restraints and evasion techniques for clinical staff. It was absolute garbage, and we recognised that when a nurse actually broke her ankle doing one of the restraints. It was quite a terrible style of training, and overemphasised de-escalation, overemphasised complacency, putting yourself into situations you shouldn't be putting yourself into. Like there was no real emphasis on the situational awareness first, making sure that you are in a safe place, making sure you're doing a real-time risk assessment and ensuring that, okay, I can step into this area now, and then continually keeping your guard up, continually being aware of what's in that patient or visitor's arm's length. Can they grab something, and can that object then that become a weapon? We're a ways from that, but that's definitely the direction we need to start heading in.
Yeah, so that sort of situational awareness, and also the awareness of there are other people around you that you can call into support. And I want to kind of move into the area, the role that security officers play, because that was a role that you held previously in various hospital settings. But, we're very accustomed to seeing security officers everywhere in hospitals, especially in ED. But what do you see as their role?
They're most certainly a physical resource. That's obviously predominantly what everyone knows about. I'm working as hard as I possibly can to get the word out that there is more to these resources than just having them stand there and stopping someone from punching you. Their wealth of knowledge, experience in all things, that's where my background's come from. That's why I've worked through to this way that I'm in now. Calling them to go, hey, we've got this guy who's presented, we're not too sure about him, what do you think? And most of the guys know who the frequent flyers are. They know, okay, this what physical characteristics are of someone who's, you know, going to probably lunge at you, or who's on some form of substance, or someone who just presents with that gut feeling that the guys of 20 years experience on the floor will know. Have them come in, have them do a walkthrough, engage them early, you know, before the fist starts swinging, because sometimes it can take the guys 3 or 4 minutes to get there. Yep. 3 or 4 minutes is a very, very long time for anything to happen. I've rocked up 60 seconds after getting a notification and there's a staff member on the floor bleeding terribly and someone on top of them. So yeah, there's so much more to those guys, well, to that team, than just saying, hey, get here now.
Yeah. Do you think that security officers have, from a work culture perspective, are accepted as part of the healthcare team, or there still needs to be work done on that?
Emergency departments, they're part of the team. They are 100%, only because they spend vast majority of their time in there. There's some areas, if you walk through with a couple of security officers, you'll see all the clinicians panic and go, what's going on, what's happened? And they actually start to get a little bit traumatized by seeing them there. So there's definitely barriers to be broken down there. And I think that's something that the senior clinical leadership and the security leadership need to work on and break that barrier down, have the guys come in and introduce themselves, include themselves in the training of the nurses, and have the security officers providing that, saying, hey, look, in these situations, it's best to do this X, Y, Z before the situation escalates. We've actually had that currently at our hospital here at Fiona Stanley. Just off of the back of our security leadership, they've provided some just training seminars, little education seminars for some of the cohorts of staff that are semi-recently starting to see verbal aggression due to the whole COVID reasons. And we've seen great successes in that. The staff interaction now, they actually have a rapport with these guys. So when they see them, they don't see some big scary security officer, they see Jeff.
Yeah, and I guess, yeah, I just live down the road from a big hospital here in Brisbane, and I spend quite a bit of time in ED. My son gets very bad migraines, and over the years that we've spent, you know, many hours in ED, you know, I've been able to witness the work that the security officers do there, and it's remarkable. And I specifically around how they manage, not that, as you've all of you have been talking about, not de-escalating, but getting things settled before it escalates. And the way that they talk to the patients is really quite magical. And I'm interested in asking you all, what kind of things do you see as, you know, for the students listening, what are the kind of things that you need to see and respond to before it gets to a crisis point? What are the signs?
It very much depends. You know, if they're on some form of substance, they're not going to seem just as the common person coming through, just as looking for help for an illness. They're going to present in some manner. They're going to be showing physical signs. You know, if they're on ice, for example, they're hyper, they're full on, they're just jetting around, they're agitated immediately off the cuff. It's very much something that definitely needs to be educated about, is the varying physical signs of these sort of things. Definitely where I see training going is that early identification, spotting the physical presentations and noticing, okay, this person is doing this and this, which typically is this reason. So this would be my response, or I will engage security early, or I will ask, you know, a quizzitive question and see what the response might be getting back. That was always mine, was the first thing to go up and just say, hey, how you doing? And seeing what their response to that is, you know, trying to break that immediate barrier.
Yeah.
Presenting as a security officer, sometimes that just break that barrier down immediately, and you know straight away. But if you just go up to them and say, hey, how you been today? What's going on? What's the matter? But also remembering to do that in a safe distance, whether that's behind a barrier, behind a bed, you know, at least a couple meters distance between you and that person, but trying to get something out of them to identify what's going on with them.
Beck, do you want to add anything to that?
I probably won't speak to the people that are unpredictable, because that's something, you know, you need to put yourself in the correct physical space to protect yourself from people that are unpredictable in general. But people that build up, in my experience, it's often around communication, and their own healthcare shouldn't be a secret from them. And taking the time to communicate where they are in the waiting queue, or why it is that you need to make a phone call before you can make a decision, or why that person's being seen before they are, or why did that happen, is really, really important. And often we feel like we don't have the time or the ability to communicate that way. I think a lot of the time in remote or even corrections, if you take the time to explain the situation, and you and I would be frustrated by 20 minutes wait to see your doctor. Some of these people wait for 6 hours, and continually get told by triage that there's, you know, people in front of them that are sicker. I think the first nurse they see, or the first clinician, when they actually make it into the department or actually get in to be seen, it's okay to say sorry. We're not going to have to pay compensation if we say, I'm really sorry you had to wait this long. We've had a really busy night. I'm going to look after you now. Tell me what's happening. It's okay to say sorry, because a lot of the time things that really start escalating people are out of our control, but they're not out of our knowledge, and we can explain them to people.
Just on the back of what you're saying, Beck, I completely agree with that informative communication side of things. We actually had a quality improvement project that happened at one of our major emergency departments, where they put together a little video of the patient journey through the emergency department, explaining, you know, if you've been given red card, you go here. If you've been given blue card, you go here, and the expected wait times and what happens behind the scenes while they're all sitting in the waiting area, and it just sits there playing on loop. And they had just amazing results from the frustrative, aggressive people who are coming up going, why am I waiting so long? It's almost completely eliminated now because of that.
Yep.
Like you said, you know, not holding out that information, they're allowed to know that. Obviously in emergency departments, they don't really always have the time to sit there and break it down for them, but to have that sitting there on loop, you've got nothing else to do while you're sitting in the waiting room. It was just such a simplistic, but
the other sort of elephant in the room for my practice and my community is racism. And I think communication and explaining the health system goes such a long way, because if you're sitting in a waiting room and you can see all these people going in before you, there is so much intergenerational trauma in Central Australia, as there is elsewhere in Australia for our Aboriginal and Torres Strait Islander community. But there is a huge element of assumed racism, and when we and proper racism. But when we can explain reasons why they haven't been seen, or why I need to go and do this process for them, but not this other person over here who happens to be white, when we can give them the reason behind that clinical reasoning we've got, it goes a really long way to fighting that negativity, or that really big and genuine concern Aboriginal people in my health centres have, that they're being treated differently. So yeah, massive communication and explaining things that generally you may not fully appreciate that you have to, because health literacy is not everyone's business. You know, we're not all taught health subjects in school and can understand what even triaging means. So yeah, assuming health literacy is a really big problem that contributes to this perception of racism, I think, in a lot of areas.
Yeah, so clearly, you know, clear communication that's respectful, and just taking the time to explain makes all the difference. And I think, you know, what you've conveyed, it would be really helpful to the students listening.
Can I just add something really quickly to that?
Yeah, of course.
There's a theory behind violence and aggression called the frustration aggression model that is basically like you come into a place with an expectation, and when that's not met, it creates frustration, and then that builds and builds and builds. It gets to a threshold where you become aggressive and violent. And we all have that threshold somewhere. And I think you could picture something in your mind, like what would it take to make me be violent and aggressive? And then there's a lot of things that go in there that lower that threshold, I think. And so like, keep that in mind. Like we all have that point where we become violent and aggressive. I found that a really interesting thing to then apply to people, that when it is like a non-medical issue, to try and understand where they might be coming from. One other thing I just wanted to add to that question from Tanaya, sorry if I butchered your name, but about intoxicated people when they first start showing signs of aggression. For us specifically in ambulance, there's often really super chaotic scenes. And so one of the biggest things for us is to reduce stimulus. And so we take people out of the environment because bystanders, it can be useful, but often are just the worst, like friends and family. To take someone out of that high stimulus environment where they can just sort of, we can focus on them and not all those other things that are going to escalate the situation. Besides your actual communication, there's those things that are really super helpful to stop someone escalating further.
I think Tony Robin, who is a nurse in your practice, she has a technique where I think if somebody's playing up in the reception area, what does she do?
She tends to come out and get them if she's got the time and just put them in another room, which is something but what I usually do with patients as they come in, particularly if there's more than one doctor, I will say your doctor has 2 patients to see before you, so that they're aware that they're going to have a wait anyway. We're in such a small community that we can say, would you like to go and get the mail while you wait? You've got 10 minutes to go and come back. And we have a sign in the waiting room that says, if you've been waiting for more than 20 minutes, please come to reception. And that way we can just update them on where they're at, whether they're next, whether they're still 2 patients away. When you've got more than one doctor working, you can have many things happening. You might have 8 or 10 people in the waiting room. Some will be going to the nurse for assessment for a driver's license before they see the doctor, so they'll visit the waiting room a couple of times. So, and then you'll get someone who'll come in and their doctor's running on time and they'll only wait 5 minutes and they see a doctor. So someone who's been waiting for a while might say, well, that's not fair, they just came in. So you do have to educate them with the information that you've got so that they know where they're at, because otherwise you end up with an aggressive person sitting there. You can see them simmering away, and then the doctor will come out and get them, and then they'll explode then, and it's too late then, because they actually need to focus on their appointment. So I think we don't deal with some of the violence that the ambulance and remote people deal with. We do have to have the skills to educate people on the system of your particular practice so that they can confidently come to the desk and say, how long is it going to be? Will I be long? You know, we say, would you like a glass of water? And it's not always successful. Sometimes it can go a little pear-shaped, but we're fortunate enough that we seem to be able to keep it not too bad.
Yeah. And
I think the practice has to educate the patients that you have, if you can, is one of the,
Do you feel as though the practice has over time become more strategic and supportive of you know, the frontline workers there?
Yeah, they are trying to, but just we have such an influx of new patients, be they travellers or be they moving to the area with, for whatever reason, and the practice is crunching at the moment with, but that's everywhere. Yeah.
I'd like to kind of turn now to the reporting aspect of workplace violence and aggression. Beck, why is it important to report incidents?
Money. No, that's a really trite answer. Trends. We need to be able to, just like at the level I sit in the health system, I can advocate all I want, but if I don't have the data to support the interventions and supports I want to put in place for my staff, I'm not going to get the money, and I'm not going to get the political will. So the Northern Territory, in a fairly long process of reviewing remote and isolated worker safety, now has a fairly, I wouldn't say live, but it's close enough to live dashboard of violence and aggression and those kind of incidents towards staff, so that all our executive team, the health minister, can click a link and see what the current trends are. It's fantastic for advocacy for the staff, but it's also really fantastic to look at, okay, there's a hotspot that's brewing and we're going to move some assets there. And often those assets are just more healthcare workers, because like we said, wait times everywhere are a problem, including in remote settings as well. And that dashboard sits in a really accessible place. And accessible, readable, clear looking data is probably the biggest advocacy tool that we can have as a profession.
So I'm just going to ask Beck, Brodie and Callan, how long, on an average, how long does it take to report an incident in your healthcare workplace?
So if you had the time right now and you clicked on the link, probably 5 to 10 minutes.
Okay.
Finding the time to do that is a different matter.
Yeah, 5 to 10 minutes is a lot of time in your workplace. Brodie, how long would it take for you to report an incident?
It's probably not too dissimilar of a system, but it'll take me about 20 minutes because I'm a bit special when it comes to computers. But yeah, probably 20 minutes, I reckon, 15, 20 minutes.
Okay.
Again, you have to be at the computer.
Yes.
Sit down at branch, have that time, be bothered to do it. It can be a little bit frustrating. Our system's not as frustrating as a lot of hospital systems, but it's still quite time consuming. Do
you have to wait till you get back to base to do that report?
We could do it on our patient care record tablets. We have tough books, but they're quite frustrating to use. So normally you would wait till you get back to branch to do it. But yeah, it takes a little while. We have to sort of click through a whole heap of text boxes and then write a detailed summary of the incident. So depending on what the incident is, it could take a bit quicker, or it could take a bit longer.
And Callan, how within a hospital system, if a nurse or a GP wants to report an incident, how long would it take them to do that?
The biggest problem with our WA Health is we've got 10, 15 different types of reporting systems. It's quite horrible in that regard. Our fastest ones, 5 minutes, they're very user-friendly. They're very, click and prompting. So 5 minutes for that. For our worst one, it's actually a downloadable Excel spreadsheet. And it took me once 20 minutes to do it. So I can only imagine someone who's not overly tech savvy or who doesn't use a computer regularly, would take them quite a while. We've even, unfortunately, still got paper-based system as well. That's how far behind we are in some of our hospitals. The biggest problem, though, even if you've got the ones that are only taking 5 minutes, especially if you're in the emergency department, you're not going to have enough time to do every single time that you've been verbally abused or physically abused. On one of those hectic nights on a 12-hour shift, you could have anywhere up to 20. You're not going to have 20. You're not going to have, what's that, 20 times 5? You're not going to have that hour spare. It's just not feasible. So the massive underreporting is always going to be a habitual problem.
So so for those incidences that are reported, what's the likelihood of that being followed up on and you knowing what action was taken? I'll start with you back and go through the same, Brodie and Callan.
It's a really complex answer, and partly because of my staff turnover. So if you stay long enough in the health service and you haven't gone within 6 to 8 weeks, because in remote clinics, often my staff turnover is that, and then you don't come back again for another 2 or 3 months. If it's a very high severity incident, it is quite quick. There are timelines, and for me, quite quick is you would know an outcome within a week. For the lower, like swearing, you may never find out what the outcome was, and there may not be an outcome. It would go into the dashboard, and it would be part of a bigger, larger sort of pool of data to say what's going on. If it's something like, look, I was in this situation and I couldn't open the safe room door, maintenance issues tend to take a while. You're going to know the outcome, but the maintenance guy might not be able to drive the 500 kilometres to your remote community with the correct piece of equipment to solve the issue. You might be given an interim solution. So it really varies, and you have to sort of stay in the health system to ever find out what happened. So often my agency staff will report and never know what happened to their query or their risk man.
But I think that's a great answer, Beck, because it covers off all the different kind of aspects that aren't necessarily obvious. Brodie, how does it roll in your area?
And so the policy and procedure is really supportive, where a team manager has to review your incident and come up with a management plan and then feed that back to you, and then come up with a report at the end, which is very time consuming. And when you look through the incidents that are reported, they're all pretty massive incidents. So I'm probably one of the few people that report lots of the more minor ones and cause a headache for people. But yeah, it depends on the team manager though, whether they actually feed that back to the staff or not, because they could just quickly say, yes, I have a chat and close that incident. But that's the expectation, is that they will do that. So in my experience lately, it's been pretty good, where you get a call from your team manager just to ask about it, see if you're okay, and talk about a bit of a plan going forward. So it's set up as a good system. But if we were to report every incident of, so it's like verbal violence as well, I think it would be overloaded quickly.
Yeah, you don't spend all your time in the meetings. Callan, what's your experience in hospital system?
I actually was in the work health safety department for a year whilst we created this workplace violence and aggression role. So I got to be frontline and understand what's going on behind the scenes when the reports came through and everything. Their response is immediate. You do get one. Is it satisfactory into what you want? The biggest problem is it's the system itself. You're limited to what you're being provided. So you can respond immediately and say, okay, we've investigated this incident. We believe more CCTV cameras need to be installed and better training. And so it'll go up to executive, and that's where it disappears and there's no response. Or maybe the response will be, yes, okay, we will take that on board, and then it's never heard from again. That is one of our biggest issues. So we always try and use the statistics to prove the point. That's where I live at the moment, is going door to door basically and telling people, make sure you report. I know it's not, it's time consuming and tedious, and you're really going to feel like it's not going to do any good whatsoever, but those statistics are being represented up higher, and we're showing that there is an issue. It is across the board. It is an entire system-wide issue. It's going to take a while. Bear with us. Just try and report as much as you possibly can so that we have something to show up above and say, look, there is an issue here. Just because we don't have the stats to show it, and try and work towards showing that there are stats.
because you've got to work with what people listen to, and they listen to stats. And I think that, that's a really positive message to receive from all three of you in regards to, the importance of reporting and of taking the time to do that. Alicia, do health workers sometimes feel there may be legal consequences if they make a report?
Yeah, sure. Good question, Meredith. So one of the things that healthcare workers have said that they're quite nervous about when it comes to maybe reporting, or maybe again how they interact with patients that are behaving in aggressive ways, is that a lot of the training and a lot of the culture focuses so much on patient safety. Patient safety is important, but when it comes to a situation where a healthcare worker is being assaulted and they have to make a choice, okay, is it okay for me to defend myself, and to what level can I defend myself? Then that can sometimes be a little bit difficult. So my natural instinct when someone's coming at me, is to eliminate the threat. And that may be to actually maybe throw a punch back myself, which is not something which is acceptable in a healthcare setting. So when they're reporting, obviously they're very nervous.
Oh, we've just lost your
because
sound again.
They think, okay, maybe when people are reading this, they're going to be analyzing my behavior. And so it comes back to these de-escalation training, that sort of thing.
Alicia, can you just mute your camera again, because we're just losing, your sound's breaking up a bit.
I've turned her video off, Meredith, but
Okay.
we may have lost her.
All right, we'll just see if she comes back.
She's got good stuff to say though, Meredith.
Yes, she has. We'll come back to Alicia.
She is dead right in what she's saying. I actually produced a guideline for our staff around reporting incidents of workplace violence and aggression to the police. Most senior leaders actually said, no, you can't do that because of patient confidentiality. And I said to them, actually, that's not true whatsoever. Every member has the ability to report these incidents to police. If they feel that they have been assaulted, they have every right to go to the police and report it. And it was identified as a massive gap in that education. So we actually built an education around educating the managers and supervisors of actually supporting their staff to go out and report to police.
Yeah. Alicia, are you back?
I am back, however, temporarily.
Okay. Do you want to temporarily finish what you were saying, because it was very important?
Okay, so if I can remember exactly where I got up to before I got kicked out. I think that I was talking about how when nurses and other healthcare workers are trained in de-escalation, sometimes they can internalize then that anything that happens is then their fault because they've been trained to stop that from occurring. And that can be quite counterproductive to having a safe workplace culture, because when they're saying, okay, everything's my fault, everything's my fault, everything's my fault, then the way that they're going to be reporting things and the way that they're going to be having attitudes to these incidents is not going to be in a way that makes things safer, but it's going to be more like blaming themselves, and that can lead to burnout. That can lead to actually quite an unhappy and unsafe workplace culture. I think that someone put in the chat that de-escalation blames nurses for getting it wrong if violence occurs, and it's not the intention when you have these de-escalation training. It absolutely is helpful and should be a tool in your toolkit, but it is, I guess, the way that we're framing this around whether or not all incidents can be avoided, because that's not true. There are some incidents that can't be avoided, and we need to acknowledge that even the best de-escalation in the world is not going to eliminate this kind of behavior from occurring. And we need to have a much more open attitude to when we're looking at incidents and debriefs around.
Alicia's conversation has made me think of something, Meredith.
Okay, this is what happened. Now tell me, how can you do that better? Do that better. So much more of a culture around that.
Thanks, Alicia. Beck, we'll go to you.
In the NT, we have some very different mandatory reporting requirements. than the vast majority of the rest of Australia. So in addition to mandatory reporting around child abuse, there's also mandatory reporting around domestic, family and sexual violence, but obviously none against healthcare workers. I mean, we have a culture of reporting violence in the NT, and I wonder how much that feeds into the really good levels of reporting that we do have. I think going back to Gail Woodford, I think her legacy, it also puts reporting of violence against remote area nurses, particularly in the spotlight for all of my staff. So I think we have a really good culture of reporting in the NTs, where I'm heading to.
Beck, do you want to share with the students who may not know the backstory to Gail as to what happened and what the outcome of her death was?
Yeah, Gail Woodford was a remote area nurse working in South Australia, and she was murdered while on call. She responded to a call out, and the findings of that coronial are readily available if you want some more information on that. What that led to is a review of RAN safety, which kind of was led by South Australia, but a lot of places around the rest of the country got a bit of a jump on South Australia's actual implementation of what they had wanted to do. So in fact, some of their stuff didn't come into operation until 2019 when they passed legislation. The Northern Territory decided they didn't need legislation. We were going to put it straight in action. So remote area nurses never work alone. If you're called to a call out, you don't see the client unless you're with a second responder, who could be a driver, who could be another nurse, or could just be a really trusted local person who's employed for that purpose. So it's a really big legacy. I think there's quite a few other recommendations that have been made out of multiple reviews around Australia. And part of that is things like secure housing for remote and isolated clinicians, the requirement to be able to, do risk assessments before you go, because that really was left up to RAN, knowledge on the job. You were just meant to be able to tell over the phone, without any sort of decision support tool or even support from management for when you said, no, I'm not going. So I would really encourage the students online it's very easy to Google Gail Woodford, and her legacy hopefully increases safety for remote and isolated workers, not just nurses everywhere.
Thanks, Beck. So that's now known as Gail's Law.
In South Australia, each state has its own approach, and it's not necessarily legislated. Yep. It's definitely enshrined in our culture, in the NT and in policy, and really would be a performance management issue. If you don't take your safety seriously, yep, as seriously as we do, then we're here to support you to do that.
Or as seriously as you take your patient's safety. So there needs to be equality in that approach to safety. I just want to spend the last few minutes just talking about an area that really requires a lot more time, but it's important, and that's about how you support yourself and your colleagues. So Beck, we'll start with you and then we'll just go around the speakers.
I'd love to speak to this. I think complacency in my profession is huge. There's going to be other issues that everyone talks to, and I probably fully support everything they say, but one of the biggest issues we have is staff being complacent about their own safety, which then breeds a culture of complacency, and then our patients become quite either bemused or frustrated when a non-complacent nurse comes along who takes their own safety seriously and follows procedure. It's a really big problem. And the less serious you take your own safety, the more you laugh in the face of the people that have gone before you, that have paid the ultimate price.
Yeah, well said. Thank you. Tony, what would you add to that?
Like I said before, I think as a whole team, we need to set the standard, and this is what we expect. Nobody should be expecting any less, or this is what the practice does. This is what we do. This is the process. This is what we expect from the patients, and that's fine to a point, but you never know what you're going to deal with. So I think we just have to try and be a team and be strong as a team. I think that's pretty important.
And Rebecca, what of your experience has taught you in terms of supporting yourself and colleagues?
Well, it's just that you really do need to take care of yourself, because it's not normal to be in these sorts of situations. If this was a domestic situation, you'd be saying, hell no, that's not okay. You need to look after yourself. So accessing resources, making sure you've got all your self-care and supports in place to keep yourself together.
Thank you. And Brodie?
I don't have anything new to add really, other than, yeah, that same attitude of like, we have it drummed into us with DRABC, the dangers always comes first. And we're shocking at following that. Paramedics have a bit of a hero mentality where you want to go and help, you put yourself into danger, you climb into a broken, beaten up old car to pull someone out. And the same can go a bit for violence. We have a really young workforce as well at the moment, with a lot of inexperienced paramedics coming through, especially through COVID. So we've had massive turnover. So being that person to encourage people and to empower them to be able to make those decisions to manage their own safety, even if it's putting someone else's health at risk. It's a big call sometimes. So trying to be an advocate for that is a big way to try and support other staff and myself.
Thanks, Brodie. And Callan?
Yeah, I suppose a lot's been said, and it's painting healthcare in a very negative light. I don't want these students to be afraid of coming into healthcare. It's one of the greatest industries. You work with some incredible people, you see some incredible moments, but be aware, look out for yourself, look out for your fellow staff. If you come into a work environment and something doesn't seem right, be inquisitive, ask a question. Is this right? Am I doing this right? What should I do here? Befriend a security officer. That's the biggest one I always tell everyone is, like, they might look big, tough and scary, but they're not. Go and be inquisitive, go and look around, ask questions, look out for yourself and your staff members. You're going to love this industry. There's horrible parts about it, but every workplace has that. Yeah.
Thanks. So that's a great note to end on. Thank you, Callan. So thank you everyone for your courage and your honesty and the stories that you shared and the knowledge. It's a hope that what everyone's learned tonight will contribute to keeping you, your colleagues and your patients safe as you navigate your health career. For those of you who are keen to learn more about this topic, the Health Workforce Queensland Student Hub has a list of resources which have been generously provided by our speakers. There are also some other links there about self-care, which you might find useful. And finally, I'd really like to express my gratitude to all the Go Raw Virtually speakers who so freely shared their time and their experience with us, as well as the Health Workforce Queensland team members who made tonight possible. And if you'd like to debrief with our speakers and this is just to show you the page that's called the Student Hub on the Health Workforce Queensland website. There are links to articles and other resources that you might find helpful. And also there's links there to previous Go Raw Virtually. The last one was mental health in the bush, so you might find that interesting to look at as well. But if you would like to debrief with us, please stay online. But thank you for coming along, for being part of Go Raw Virtually, and good night.